Good evening. Thank you for being here. I see a couple of familiar faces, but if some of you guys who have diabetes will raise your hand so that I know what audience we're going to be talking to. Awesome. Okay, because when I was preparing this lecture, I was not sure how in-depth to go, but I think that I got the right crowd to talk to. And we'll talk a little bit also about prediabetes so that we know what to do not to progress to diabetes. That will be something very important. All right. Carol would like the questions at the end, but I'm perfectly okay if you guys feel like you want to ask a question before we move to the next slide. We can do that as well. So I have nothing to disclose, so I'm not paid by any company. I'm just bringing you guys what I saw on the internet, and I'm going to talk a little bit about my personal experiences. We'll talk about some interesting things that I found that are coming down the pipeline. So that means that things that will be available probably in the next couple of years, and I think that those are very hopeful and will make your lives easier as diabetics. So objectives today are to identify symptoms and signs of diabetes for those of you who do not have diabetes or who may have friends that are feeling a little bit sick so that we can get them diagnosed and appropriately treated. Discuss different ways to diagnose diabetes so that we have an understanding of what needs to be done and we can search for that management. Discuss benefits of recent therapies, and what I mean about recent therapies, probably in the last 2 to 3 years. I still talk sometimes about some of the therapies, and some people just are not aware that those are available, and that those would decrease how many times you have to take medications or what kind of side effects you would have. So those would be interesting, and you can bring that up to your primary care providers. Discuss side effects of recent therapies so that you know when you're getting started on a newer medication, there's a lot of apprehension. Has this been long enough in the market? Am I a guinea pig? That I hear that a lot, so that you would be aware of what to expect and what things that are out there that may not be absolutely true. Discuss the role of weight loss in diabetes management, and that in the recent years has become more and more important to address that instead of just trying to pile up a lot of medications. So what is diabetes? Diabetes is just a problem of high blood sugar caused by difficulties producing insulin, about how insulin works, or both of them. So you can have a defect in the production, you can have insulin that just doesn't work well, or insulin that even if it's good, is not working well in your tissues. So those are the main things that are happening in diabetes. So why are we so worried about a number? Because some people just don't have any symptoms. I have patients sitting in my office, my blood sugar is 400. Doctor, I feel perfect. So we're worried not about that moment. We're worried about what could happen next. So strokes are serious complications of diabetes, heart disease, amputation, kidney failure, and early death. So those are the things that we're trying to prevent. Even though we're feeling perfectly fine with the high blood sugars, we just want to make sure that down the line we don't have any of these problems. So normally insulin is produced in the pancreas, and pancreas is an organ that we don't talk a lot about, but it's very important. It's in your belly, in the posterior part, and that insulin that pancreas produces makes that helps the cells absorb the sugar, and the sugar is just the unit of energy that we use. So if that sugar stays in your blood and it does not come inside your cells, it can become toxic, and all that buildup of sugar in your nerves, in the kidneys, and in the eyes are the ones that are bringing up the complications. Also, the pancreas produces a hormone that we don't talk a whole lot about, and it's called glucagon. Some of you who may have type 1 diabetes may have at home a glucagon shot, and that helps you to rescue when the blood sugar is low. So the pancreas also produces that hormone, and it helps keep your blood sugar up. So that glucagon helps keep the sugar up when you're fasting. So the diabetes also affects that production. So down the line, after you've had diabetes for a long time, the production of glucagon can go down, and sometimes that's why we wonder, why are my blood sugars dropping? I didn't do anything to cause that, and there is no rhyme or reason for my high or low blood sugars. So glucagon also has a lot to do with that, and we'll keep that hormone in mind, because we're going to talk about it at the end of the talk with some of the newer developments that may come out in the next couple of years. So also we talked about that toxic buildup of sugar in your body. If you have a lot of sugar in your blood, that also is going to bring water out of your cells, and you're going to get dehydrated, and all that's going to come out through the urine. So that's when you feel like you're urinating a lot during the day or even at night. Sometimes people just say, I'm too fatigued during the day, I don't know what's going on, I can't sleep. And I ask them, why can't you sleep? Are you waking up multiple times in the night to urinate? And that may be the problem. So some of your family members or friends that say, I am fatigued, I cannot accomplish my daily tasks. That's one thing that you guys could ask, are you urinating all night? And maybe the problem is that they could be having diabetes. So with excessive urination comes the thirst. And that's another thing to differentiate. Oh, I drink a lot of water. Is that because you're trying to be healthy, or because you actually feel thirsty all the time? And that's a good difference. If you're drinking 8 to 10 glasses of water, that is awesome. That's great. You're doing better than me. But if it is because you're feeling very thirsty, that may mean that your blood sugars are running higher, and we need to do something about it. So what types of diabetes? That's a question that comes out all the time. Doctor, am I now a type 1 diabetic? And there is a difference. Type 1 diabetes is an autoimmune problem. You have some pieces of your body that are working against your body. They go to your pancreas and attack it. They really don't know what they're doing. And that's what causes your type 1 diabetes. And you just don't produce insulin later down in life. Then you have your type 2 diabetes. There's a lot of factors. There's diet, there's activity, and there's a lot of genes working for that deficiency in insulin. Then some of the natural progression of diabetes, of type 2 diabetes, is to go to an insulin deficient state, but that doesn't mean that you become a type 1 diabetic. You're just a type 2 diabetic that is requiring insulin. Gestational diabetes, I also see a lot of that around here, and it's because of the hormones that your placenta produces to keep your baby growing. Also can produce problems with the insulin working, so you become what's called insulin resistant. A lot of people can most women can go through pregnancy and not have any problems with blood sugars going up. But some of them, if you have a baseline problem, maybe you don't know about prediabetes or problems managing your blood sugars, or you're carrying a little bit more weight than you're supposed to, you can then have gestational diabetes. If you do have gestational diabetes, fortunately, after the delivery, most of it goes away. But you still have that memory in your body, and that could mean that later down the road, you have higher risk of developing type 2 diabetes. So people with, the females with gestational diabetes, after they deliver, they may not need any more treatment, but they do need appropriate follow-up. They need to go to their 6-week post-op check and get checked for type 2. Maybe they did have type 2 to begin with and they just didn't know. Or they ended up having prediabetes, and that needs to be followed and checked. So that's another important thing to tell your daughters, your neighbors, about if they have gestational diabetes. That 6-week follow-up is very important, and sometimes we're very busy with the baby and don't go to our follow-ups, but it is super important. LADA is latent autoimmune diabetes of the adult. It's sort of a type 1 that's diagnosed later in life. So most of your type 1 patients are going to be diagnosed during their teenage years or their childhood, but some of the autoimmune problems can also happen later in life. And the importance to differentiate that from a type 2 diabetic is that these patients do need insulin right away. If not, they'll become sick. And MODY is a special category of diabetes that we have identified which gene is causing the problem, and that has a very specific therapy that that people respond to. So there's one very cheap medication that will help. So that's also important to identify. There are genetic testings that we can do for that, depending on how people look. and if they don't have the characteristics of type 2. So how many people have diabetes? We have 29 million people that have diabetes in the United States. This represents 9% of the population. 8 million of those are undiagnosed. So that's where the importance comes, the awareness of the symptoms. We need to help find these people, because if we help them to get treated, the complications are way less. And more than 40% of the remaining 21 million are not under control. So we are not doing a very good job. We should have more people really under control of those who are diagnosed. So in average, when you diagnose a person with type 2 diabetes, they've been diabetic for 5 years. And that's where that 8 million figure comes from. So how many people, that's pretty much the same thing that we talked about. These numbers were, I put this slide I used in 2012. So if you see, the number has risen a whole lot. We had 18 million of people with diabetes, but now we're up to 21 million, and undiagnosed we're 7, so there's a whole new million of people undiagnosed with diabetes. So pre-diabetes is where I wanted to show you that there's 79 million people who have pre-diabetes. So we need to identify those, address those, and do something about it, because we can prevent the progression to a certain extent, or at least delay it from pre-diabetes to diabetes. This is a nice map of the progression of diabetes in the United States, and I just wanted to show you that West Virginia, it has a little bit more diabetes than the rest of the states. It's on that red little dark maroon color, so we're more than 9%, so we're higher than the national average. So we need to pay attention to the symptoms. So what is prediabetes? So your blood sugar is a little bit higher than where it should be, but it's not as high as what we would diagnose with diabetes. So if your blood sugar is between 100 and 125, and that is a fasting blood sugar, meaning you shouldn't have nothing to eat for 8 to 12 hours before that sample, you have prediabetes. So if you don't do anything about it, and we just looked at the numbers in 10 years, if no intervention are made, we think that those people will progress to diabetes. So prediabetes is an opportunity to improve your lifestyle, to improve what you're eating, to increase your exercise. So usually there's no symptoms from it. There could be a little bit of weight gain, and an important sign of insulin resistance is acanthosis nigricans, and what that is a little bit darkening of the skin in your folds. It would be, your skin would be darker in your neck, under your armpits, and some of the skin folds. So that's something that we can also start paying attention in our children and our family members. If we see that, they need to get checked for insulin problems. What are the risk factors to have prediabetes, and who needs to get screened? Overweight, if your waist circumference is larger than 35 in female or larger than 40 in man, and that goes along with your pant size. So if you wear a pant size, if you're a man larger than 40, you should get checked, or 35 if you're a female. If you're not very active, if you have those darkening of the skin folds that we talked about, age older than 45. Some races unfortunately have higher risk of having pre and diabetic, like Hispanics, African Americans, Pacific Islanders, and Native Americans also have higher risk. Your family history, mom, dad, cousins, then we should be paying a lot of attention to that. If you did have gestational diabetes, and not only gestational diabetes, but if you ever had a baby that weighed more than 9 pounds, then that's somebody who needs to be taken care of. In the past, the cutoff to diagnose gestational diabetes was a little bit higher. Not everybody got screened. Now we're getting more aggressive at screening pretty much everybody. So if somebody had a baby that was larger than 9 pounds, definitely needs to be evaluated for diabetes. The polycystic ovarian syndrome, so females that have that are a little bit overweight, that have irregular menstrual periods, or have a little bit more hair, then if they have been diagnosed with PCOS, they also need to be watching their blood sugars. And importantly, sleeping less than 5 hours puts you at risk for diabetes. If you're a shift worker, if sometimes you work at night and then you change to days, that really messes up your circadian rhythm. So sleep is very important to keep your blood sugars down. And the other thing is that when you're sleeping, you're not eating. So that is very, very good. So we need to try to sleep 7 to 8 hours. Those are 7 to 8 hours that we're fasting. How to prevent the progression. So what do? I had a couple of blood sugars in the last couple of years after I went to see my primary care doctor. They were 110, 120. What do I do now? Do I sit here and wait for 10 years to have diabetes, or do I do something about it? Yes, we're going to do something about it. We're going to try to change our diet, and we're going to try to do a little bit more exercise. And we're going to keep checking those blood sugars. You don't really need to do finger sticks at home. Some of my people, I do have them do finger sticks depending on my level of suspicion that they're going to be progressing. But really is not necessary. But going to your doctor, going to your appointments, following up, making sure that that fasting blood sugar is coming down and we're dropping down on the weight. There was a very interesting study that came out in 2002, so over 10 years ago, that showed that lifestyle intervention is even better than medication. It works better than metformin. But for some people that you're looking at their blood sugars, they're coming up, they're trying to do as much as they can. Maybe they just have a higher genetic background. They have 3 or 4 genes that are affecting them, and they're going to have diabetes. So to those people, sometimes we do recommend medication. So some of them we do start on medication called metformin to try to help them not to progress to diabetes. So that's the reason why some people take medications and they tell you, I'm not really a diabetic. So how do I diagnose diabetic? So diabetes, how do we know if we have it? There's a couple of tools that we use. Really, the Hemoglobin A1c is one of my favorites. It's fast. I can do it in the office. You guys can have it done at your primary care provider. And if it's higher than 6.5, it comes in a percent, and it equals it's an average of what your blood sugar is. So if it's 6.5 and above, you do have type 2 diabetes. If it's in that gray area between 5.7 and 6.4, that's a diagnosis of prediabetes. So we need to keep checking it, and we need to do exercise, and we need to do lifestyle changes. If you are going by your fasting blood sugars, which pretty much every of your primary doctors are doing it at least once a year, if not, some of them do it every 3 months. So we are looking for a blood sugar higher than 126. And the difference with the fasting blood sugar is that we want 2 for confirmation. So if you have a blood sugar between 100 and 125, that is what we call impaired fasting blood sugar, so it's not good. And that's one of the classifications of prediabetes. In prediabetes, you can have a problem with your blood sugar once you wake up, once you have not eaten anything, or you can have a problem after you've had something to eat. So if you have even one blood sugar higher than 200, there's really no question about it. You do have diabetes. So there's no emotional diabetes, or I was on steroids, or I was in the hospital. If we have a number higher than 200, that's it. If you have been taking prednisone or any of those similar medications and your blood sugar was higher than 200, you still have diabetes. You just have something that's called Glucocorticoid-Induced Diabetes. And to some people, that kind of goes away if you stop taking the medications. But probably people that have a high blood sugar like that after they take medications, they probably do have some prediabetes underlying. The other test that was very common in the past was that oral glucose tolerance test. So any 2 hour higher than 200 will diagnose diabetes. So what they do is they have you come fasting, they give you a very sugary drink, and they check your blood sugars in 2 hours. So higher than 200, then again we know that's a diagnosis of diabetes. And between 140 and 199, that's another of the pre-diabetic states. So even though you don't have diabetes, that does need follow-up. So as we talked before, usually diagnosed in children is type 1 diabetes, and it was previously known as juvenile diabetes, but now since more people fortunately are surviving, we don't call it juvenile diabetes anymore, we just call it type 1. Only 5% of people with diabetes have this form of disease. So even though it's a little bit rare, we have quite a bit of a group of people with type 1 that I take care of. And this is a little bit more of what we've already talked about. Usually in overweight adults we see type 2, but we're starting to see it more in children. So we need to watch our kids and our grandkids and what they're doing, and especially what they're eating. This is a graph to show what insulin resistance means. What that means is that we do have enough insulin running around. It's just that that insulin is not doing what it's supposed to do. So that insulin is going to be your purple triangles, and it's going to go to the insulin receptors, which are the little things in green, and that is going to open another receptor, which is your yellow receptor, and the other blue little substances, that's sugar. So if you don't open that, the sugar cannot go in, and that's what insulin resistance means. Even as though it's there and it's going to your receptors, it's just not working properly. We talked about the gestational diabetes, and it's that placenta that's making block the action of the mother's insulin in the body. Who is at risk for gestational diabetes? Overweight females. If you've had gestational diabetes in previous pregnancies, or if you've had a baby larger than 9 pounds, then you're also at risk and you should be checked. Women at both ends of the age group, meaning very young, 14, 15, or at the other end of 35, 40, higher risk of gestational. And then again, the race is very important. African American and Hispanic females are a more risk of gestational diabetes. What are the symptoms? So your blood sugar goes high, and if you see those symptoms that are in blue letters are those that are more common in type 1, but you can have pretty much all the symptoms. So sometimes even nausea, vomiting, and belly pain can be a symptom of diabetes. We talked about urinating a lot. Though sometimes your breathing can become uncomfortable, especially if your blood sugar has been very high. And that smell of acetone, like a sweet smell to your breath, that could also mean diabetes. Systemic weight loss, when your blood sugars are very high, you're urinating a lot of calories, and that could give you that weight loss. And just feeling tired, feeling like you're lethargic, like you just don't remember things as before, or that could also be a symptom. A little bit more of that. These are more symptoms for type 2. Frequently tired, always hungry. Having frequent yeast infections can also be a telltale of diabetes. Always thirsty. Blurred vision is a big one. Sexual problems, and sudden weight loss. Some of the complications of diabetes are blood vessel damage that can cause some tissue damage and some nerve damage. That's what the nerve damage is, what we call diabetic neuropathy. The eye problems and blindness, that's something that is very important because it decreases your ability to take care of yourself, to drive, and to do all these things. And most importantly, when you have eye problems that are caused by diabetes, sometimes you don't have any symptoms until you just lose all your vision. And blindness is the leading cause. Diabetes is the leading cause of new cases of blindness at 20 to 74 years of age. There's 4.2 million people with diabetes, 40 or older, had diabetic retinopathy. So we need to address that, and that's why you're asked to go to the eye doctor every year to have them taken care of. The new guidelines are that just came out in 2015 say that if you have been stable and you've been having eye exams and you don't have any retinopathy, the eye exams could be delayed for 2 years. We'll see how that goes. Complications, other complications that are very feared are kidney problems. And it's the leading cause of kidney failure, accounting for 44, pretty much half of the cases in the United States. So a lot of people that are on chronic dialysis or have had a transplant are people that also have diabetes. Life expectancy, how long you're going to live, is going to be shortened by 5 to 10 years. So we need to really take care of that. 2 to 12 times the risk of heart disease. 2 to 4 times the risk of stroke. Number 1 cause of blindness. It plays a role in amputations, even though it may not be the primary problem, and sends 50,000 diabetics every year to dialysis. You also have higher risks of cancer, breast and uterine cancer. How to prevent all those bad things is just with good blood sugar control. And something that is good and also bad is that the body has what's called metabolic memory. So after you've had very good control for 7 years, some of that protective thing that you gain with your body is going to remain with you for another couple of years, and there has been studies to that. So what we're doing is going to pay off down the road. The American Diabetes Association also has some gold medalists, meaning people that have had type 1 diabetes for 50 years and they don't have a single complication. So that means that people have done it in the past, even with less tools than what we had before. 50 years ago, we did not have glucometers. So if those people made it up to 50 years with no complications, we can do it too. So we just need to pay close attention to what we're doing. How to treat, what do we do? We're going to talk about a lot of medications, but I really want to stress on diet and exercise. So what are the barriers for us not to be able to do diet and exercise? Lack of time. Sometimes we work hard schedules, or we have a lot of things to do. We have grandkids at home. So try to see where you can fit it in. Can you fit it on the weekends? Can you wake up a little bit early in the morning? Can you do it in the evenings? So figure out a time that would be good for you. What's good for me doesn't necessarily mean that it's good for you. But anything that you can do is good. If you can put your stationary bike in front of your TV and enjoy your favorite show, that's good. To some people, what I tell them is when you're watching your favorite show, just go around your couch every time they're putting all those ads, and you're probably going to be walking for at least 20-25 minutes of the show. That's true. There's a lot of ads, and they're putting all those commercials for food, so just walk around and look at that. Invite family members, invite your friends, get a group to go to the gym with you. They'll call you, they'll harass you, they'll ask you to go, and that will keep you going in days that are very cold and all you want to do is stay at home. But if someone is calling you, you are going to go. So you influence positively some people, and they will influence you positively too. Sometimes we don't want to go because we don't feel energized. We're tired. Try a time of the day that is your best time. Some people feel better around lunchtime, so that maybe that's the time that you should go if you can make it at that time. But schedule the activities when you feel energetic, and eventually exercise will increase your energy. It does take 3 to 4 weeks for you to feel more energized from exercise. So if you go and you feel wiped off, that's going to happen, but you're going to feel better down the line. Lack of willpower. Sometimes we just are not motivated enough. So try to have a weekly schedule, join the exercise group, and then set small reachable goals. If I say today that I'm going to go to the gym 6 days a week for 2 hours, I'm probably not going to be able to make it. But if I say I'm going to start with 3 times a week and I'm going to do 20 to 25 minutes, I'm very likely to reach that goal. And then after I master that, I'm going to start putting a little bit more, because your goal is to exercise 150 minutes every week. So you can start with 15 minutes. If you started, you have half of the battle. Fear of injury. Some of us are worried, do we have knee pain? Do we have back pain? There's a lot of things that you can do. If you have some of knee and back pain, you can go to the wellness center, you can go to water aerobics, or you can talk to someone who's experienced in exercise and can tell you some modifications so that you can do the things that you may think you can do, or maybe with time you'll be able to do. Start slow, but move forward. Lack of skills. Sometimes we think that we just can't do it. Go to the class and see if you can. If you cannot, just come out of the class and try something different. Lack of resources, and that's a biggie. Sometimes we just don't have money to pay for that gym. Well, we'll do something different. We're going to go walking in the mall. We're going to take the stairs. We're going to buy a used videotape. I'll give you some ideas later on. And there's some inexpensive community programs that we can try to reach. And maybe that's going to help out. Walk whenever you can. Walk instead of driving whenever we can, not when it's cold. Please don't fall outside. Walk with your children to school and your grandkids if it's close. Take the stairs instead of the elevator if you can. Try to make it a family deal. Take a family walk after dinner. Go for a half an hour walk instead of sitting and watching TV. Always park at the end of the parking lot and walk to the store. Make it a habit. Everybody's going to come out. It's going to benefit everybody. Let's go on Saturdays. and or take the dog on longer walks. That may be good too. I know that during the summer around here, blood sugar does get better because everybody likes working on their garden, and that is very, very good. Do house chores, wash your car, anything that you can do is going to help. You just have to be creative. Play with your kids at least 30 minutes a day. There's a big campaign, Play 60, so those kids need to be 60 minutes outside and walking and not playing with that Xbox. The other things that I would like to stress is give yourself a goal start with non-food related rewards, such as a family day at the park, lake, or the zoo. And this is very important because sometimes, and I was very guilty about that, I would say, if I do this, I'm going to go and eat. If I lose 5 pounds after I do that, I'm really going to eat that lasagna that I really like. No, that's negative message. You have to do something different. So now, if I'm very good and I do my exercise, then I'm thinking of something different. Maybe I'm going to buy something that I really like and I really want a pair of shoes, or I'm going to go for a massage or something different that's not food related. Things that you can buy and that are not expensive and not very, very expensive. These are the cheapest that I found. Dance and Be Fit, used $5.99. Biggest Loser Boot Camp, $3.99. Some ballet, if you would enjoy that, $6.48. Yoga for weight loss, Sit and Be Fit. Those I like those last two. If you have joint problems, Chair Aerobics for Everyone and Sit and Be Fit. Those are really good. And Pam Guessfer loves those too. Gym for free. Okay, I don't want to pay $3.99. That's fine. We're just gonna, if you have a treadmill, if someone does not want their treadmill, you may want to tell them, oh, you just need to get it out of your house, and you get it. And the last one that a patient told me the other day, which I thought it was really cool, is you can go to YouTube and there's a lot of videos there, and you can just do it at home. So that's cheap. If we have internet, we can do that. And there's Exercise TV also on Comcast. They put videos, they change it every 6 weeks, and that's really, really good. And other cable companies do have exercise on demand. So those are very good things that you're already paying for, that you can take a little bit more advantage of. Always stay hydrated, stretch, wear the correct shoes designed for walking so that you can prevent any injuries. Your walks don't have to be long. We just have to do a little bit of walking. Eventually we'll get there. Wear your diabetic ID if you're going outside on the road, just in case if you have a low blood sugar, if you have a problem, people can help you. And carry a snack to eat if you're going to be active for a long time. If you're going to go on a hike, that's probably a very good idea. Right, we're going to move forward so that we can get to the newer medications. So the SGLT2 inhibitors are a newer class. There are 3 in the market in the US. One of them is called Jardiance, the other one's called Invokana, the other one's called Farxiga. They're pretty similar. Invokana can be used if you have a little bit of kidney impairment. The other two, probably best to stay away from. How do they work? And this is a very neat mechanism. You see how when your blood sugar is high, you're urinating a lot of sugar? That's what this medication does. It makes it when your blood sugar is normal to get rid of it. So that means you don't have to, in the normal person, you start urinating anywhere from 150 to 180 when your blood sugar is there. When you have diabetes, sometimes you lose that ability. So that threshold of when you start urinating and trying to get rid of your body has that as a safety mechanism, goes all the way up to 210. So I don't want to wait until my blood sugar is 210 until I start trying to get rid of it. So what those type of medications do is they bring that threshold down to 70 or 80, so you're starting to get rid of it earlier. They have worked pretty well, and they're they have been very, very good in the last year or so. What can we expect from that? We can expect a little bit of weight loss because you're losing a little bit of water weight. You can expect increasing urination, especially during the first week or so of using it. Then eventually everything kind of evens out. There's not a lot of low blood sugars unless you're using it with something else that promotes low blood sugars, like insulin or other types of medications. And but if you're using it on its own, there's minimal risk of hypoglycemia, the low blood sugars. And there's also a good benefit of blood pressure reduction. So this is why I like it. You get a 1, but you get 3 benefits. Blood pressure comes down, so most of the time I'm able to cut back on some of the blood pressure medications. You lose a little bit of weight. It's not 50 pounds, but it's a good 10 pounds. People are very happy about it. And then you also decrease the blood sugars. So that's why I like them. What are the side effects? Because of course, everything comes with its side effects. As you're urinating all that sugar, you're putting all that through your urine, and then you can also have urinary tract infections. Most of the time is that first one, you treat it and you're okay. But some people do have recurrent urinary tract infections. And the same principle with the yeast infections. You can have low blood sugars if you're using it with insulin. Sometimes if I'm adding that as a therapy, I bring the insulin down depending if people are well controlled or not. You can get dehydrated. And there's been a question of bladder cancer with one of them because there was a preliminary study where 2 people developed bladder cancer. It hasn't been reproduced in other studies, but we do keep an eye on it. And it was only shown on 1 of the 3, not on all 3. So maybe it was not cause and effect, but we do keep a close eye on that. So who are not a good candidate for it, even though I really, really like it, if you have a lot of recurrent urinary tract infections, this is not a good drug for you. Or if you're a female and you're having to battle with yeast infections, maybe it's just not good for you. Or if you start taking it and you've never had these problems and you start developing, maybe it's a good idea just to stop the medications and try something different. Dehydration also, I try to stay away from it. If some of the more elderly people, if they didn't drink enough water, live alone at home, and they have been admitted a couple times for dehydration, then maybe that's not a good person to treat it with. Also, people with prostate problems that are already urinating a lot may not be a good fit for the drug. But some people want to try it and they do well. But those are the type of people that I would stay away from. The GLP-1 inhibitors, they have been around for close to 10 years. Some of you may have heard it. They're called, the first one was Byetta. We also have Victoza, Bydureon, and more recently we have Trulicity and Saxenda, and I'll tell you what is the difference with those 3 at the end. So that I'm talking about them not because they're new, but because they have newer delivery mechanisms that have made them very attractive. What are the adverse effect of these medications? It comes because of the way that they work. They decrease the stomach transit, so you feel fuller faster for a longer time. And that's where some people can have that constipation, that belly pain, initially nausea and vomiting. But what we've seen is that the more extended release the medication is, the better tolerated it is. So people that tried Byetta at the very beginning when it came out had a lot of nausea and vomiting. But people that have tried the newer ones have felt much better, and they don't have as many side effects. So if you've tried one of the earliest ones and it didn't work, maybe you are encouraged to try the newer ones. What people don't like about it is that they're injectable. But for example, Bydureon, you inject it once a week, so that's that's convenient. I like that one. Bydureon just came out with the Bydureon pen probably like 6 months ago, which has helped because before it used to be a kit where you would have to mix a lot of things. Now everything is in the pen and you just roll it up and it will get mixed, and you just tap it in your hand so you can mix everything yourself in the pen. Trulicity came out like 3 months ago and it's already pre-mixed. You pretty much don't have to do anything. So it's been one of my favorites recently. You just put it on top of your skin, you open it, like open and close, and we have a couple of demos out there. We can show you some of those if you would like. And then you just press on it. The other good thing is the needle is small. You don't have to dial a dose. So if you have problems with arthritis, this is a good product because you don't have to be dialing things up and mixing it. And the other thing is you don't see the needle. And sometimes we're only worried because we see that needle, you put it there, you press on it, it will inject you, and then it will also take it out for you. So I like that product because of that. Some people don't like it. They say, I don't like to be poked if I don't know how deep it's going to go. I like to do it myself. So it's not for everybody. So that's how you do it. You just uncap the pen, place it on your skin, press on it, hold, and you're done for a whole week. Tansium, I'm just aware of it. It's been out for a year. It has to be mixed, but you mix it in the own syringe just like the Bydureon does. So it's not a very popular product around here. We just saw it pop up in a prior authorization last week. So I don't know a whole lot about it. It's out there. It's once a week also. So maybe we'll start seeing it a little bit more. I wanted to show you about Levemir Flex Touch, because if you're on insulin and you use Levemir, you may start seeing this product because they're gonna start fading out your other pen. What's the difference between Levemir Flex Touch and Levemir Flex Pen? Absolutely nothing. It's the same pen, it's just that the delivery mechanism is much better. When you start dialing your dose, it doesn't come out so that then it's hard for you to press. You just push on the button and it all comes in. It is the doses that the pen holds. You can dose up to 80 units. The other one you could only dose up to 60, so that's much more convenient. Everybody that have switched to the Flex Touch have liked it better. They feel that it's easier to deliver and that their lives is a little bit easier. So that's something that has come out recently. I also like the NovoPen Echo. And NovoPen Echo has been out for a long time. This is one of their newer versions. And the reason why I like it is if you see on the dial, it says 5.5. So that's telling you how long has it been since you've dosed your last insulin. Sometimes we say, did I really do my insulin? How long has it been? Did I do it? Did I sit here? Did I take it? So the NovoPen Echo can help you with that. The other good feature about the NovoPen Echo is that you can dose half units, and sometimes that's useful for kids or people that are very slim and where you need to do very fine titrations. Again, it's not for everybody, but something that is out there. And they have it in cool little skins for kids, so that may be good if one of your grandkids do need to use one of these. I also came across this Insulin. It's not covered by insurances, but you can buy it. It'll tell you how long has it been since you used your pen. What you do is you replace the cap of your pen, and it's not only comes for Levemir, it comes for your Lances, it comes for your Humalog. You can get it online, and once you cap the pen, it starts a timer. So you can see it's been 32 minutes, so yes, I really did it. Or it's been 26 hours. I really didn't do it this morning how I was supposed to, so you know that you need to go and do it again. If you open the cap for less than 8 seconds, it won't set the time again, because sometimes you have to look at it, do I need to call the pharmacy for a refill? So you can open it for a short period of time and put it back, and the timer will still be set up. I really like that product. One thing that's coming out this year is Afrezza. It was approved by the FDA last year, and that's the inhaled insulin. We had a little trial with inhaled insulin in 2007. It was not very popular. I think the providers really didn't like it, and the patients felt a little bit apprehensive with it. The Afrezza then starts acting faster than the insulin that we inject. It gets absorbed through your lungs, and then it gets built up in your blood. Who cannot use inhaled insulin? Anybody that has any lung problems. So if you have COPD, if you have asthma, which is a big portion of my population, you can't use that. If you have been smoking or recently stopped, is also not for you. And the reason for that is because in some of the trials they saw that some lung cancer popped up. But when they went back to evaluate which patients had lung cancer, they also noticed that they were smokers. So what they're trying to do is have people that have risk factors for lung cancer stay away from it, so we don't do any harm. It shouldn't be used when you have an emergency like diabetes ketoacidosis, so your blood sugar is really high, you need to go to the hospital. You just can't use your inhaled insulin. You have to use other ways of administering insulin. What I think is going to be a little bit confusing and cumbersome is going to be the dosing. So if you use 4 units, you're going to use a little blue cartridge. But if you're using 8 units, you're going to use a blue cartridge. So if you're combining and you need to use 12, you're going to use one of the green and one of the blue. So I think that we're going to have a little bit of confusion, especially at the pharmacy end, and on how to dose. What did you do? I did the blue, I did the green. So that's something that we also need to be very careful with. It has to be somebody that is very on top of their things and are very careful with it. So if you see on your left is Exubera, and that's what it was in 2007. And that's part of why it was not popular. Look at how big the device was. You don't want to go to the restaurant and bring that thing out and have everybody see you like out of space. You don't want to do that. So the Afrezza in 2015 is very small because they knew that that was part of why the patients did not want to use it. So maybe this is going to have a little bit more of acceptance in the public. We'll see. Gentile also came across my radar. I think it's a pretty neat device. They are marketing the GentDeal as being pain-free lancing. They say you can use your same lancets with that device. It's just not going to poke you deep enough to touch your nerve. It's just going to poke it in the very surface. And that little vacuum that you see on the bottom is going to suction your blood. So they say pretty much pain-free. So that's another thing that I'm very curious about trying it. It's an European product. You can buy it online. It has 5 years of warranty. It costs $125. So it's not something cheap, but if you're testing 7 times a day and you have an insulin pump, maybe that's something that we need to consider. And they are also like money back warranty. But I cannot tell you because I don't have any experience. I haven't used it. I haven't seen it here, but that's something that's out there. You can put cool skins if you have a kid that's using it. Maybe that's somewhere that you could try that. If you have your grandkid, Christmas gift, maybe that's something that we want to try. AccuCheck Expert has become also one of my favorite products to use. What is it that AccuCheck Expert does? Checks your blood sugar, but when we're doing calculations that are a little bit more difficult and take 5 units before each meal and you're counting carbs, sometimes the math becomes difficult. And you have this big thing, take 1 unit for each 50 grams of carbs and do that and do this and add 50 and then subtract 5 if you're exercising. So the AccuCheck Expert can do all that for you. And all you have to worry is about counting your carbs. So it allows you to do a little bit more accurate calculation of insulin, and it decreases the burden of time that you have to sit there and think about. AccuCheck also has a pump that is very similar to that, and I think it's a very neat technology. Some of my patients have really enjoyed doing that, especially type 1 diabetics that are not ready or do not want to go on the pump. They try this and then they benefit from some of the features of the pump, but they're still not attached to anything. Medtronic 530G. I really like this pump because it has that threshold suspend. So what is threshold suspend? What threshold suspend is that you have a sensor under your skin that's sensing your blood sugars every 5 minutes, and then it can tell the pump the blood sugar went under a certain value, and if we set it at 60, blood sugar's under 60, turn the pump off. So that's a neat safety mechanism, because I know that around here the main apprehension with the pump is that there has been a couple of very unfortunate events where young people have died after having a pump deliver a lot of insulin. I don't know how much of that has been human error or how much has been the pump failing, but people have a couple years that happened, and there's still that, I knew so-and-so and she died on the pump and I'm really not willing to try that. So that threshold suspend can help eliminate some of that apprehension. It helps because it decreases the risk of low blood sugars. It's not failure proof. Sometimes the sensor can tell you're low when you're really not, so you still have to check your finger sticks. But I think it has everything on the same receiver, so it's very comfortable so that you don't have to be carrying around a lot of products. Dexcom, I like this sensor. It's really accurate. It doesn't beep a whole lot. I've liked wearing it. I wear some, if I have the chance to wear these products. I don't have diabetes, but I wear them, I try them, I poke myself so that I know what I'm talking about when I'm recommending it to people. So I've worn the Dexcom. I really like it. It's very accurate. It is true. You can leave it here and then you can go somewhere else and it's still reading. So and when you come back, it will take all that data from the sensor. So it's very neat. And now Dexcom is going to be partnering with some of the pump companies to do something similar to what we saw in the 530G. Omnipod is a popular pump in the younger populations who don't want to have a tube. The insulin pump is that little white ball that you see there, and you put it on there's just a little cannula that goes under your skin. It looks like 2 human hairs. And that was another thing that I wanted to relate to you guys. Sometimes people don't want to have an insulin pump because they think that they have to go to surgery and have the pump inserted, and that's not absolutely true. You can change that pump you have to change that pump every 3 days, and it's just a small little tiny cannula that goes in. Pump users, children use pumps. Even little babies, unfortunately, if they have diabetes, sometimes it's better to have them on a pump because the parent can control and can remotely give them insulin. I don't imagine how it would be to chase that little kid around and let me just give you a shot of insulin because you're going to have a meal. That would be terrible. But they can also benefit from those kind of technology. The Animals Vibe also came through my radar. I was not very aware of that kind of pump that had that Dexcom meter that I told you guys about. That now it has it fully integrated. We don't have a lot of Animals pump around here, and I think part of it is probably the coverage for the insurance. T-Slim is pretty neat pump. It's touch screen and it has a very nice LCD pump. It looks like a little bit of like an iPhone. So some younger people really enjoy that pump. Freestyle Libre, I also came across that product and I am absolutely in love. I want to buy one of those. So what that is if you see on his skin, he has the sensor on, and all he has to do is flash what he has on his hand, which is the receiver, and that will be checking his blood sugars. He can do it as many times as he wants, and it is every 5 minutes, and that's kind of like the very beginning of not having to do finger sticks all the time. So I'm very excited about that product. It's not approved in the US, even though I tried to buy it online, I couldn't because it detected my IP address has been from the US. But we'll see how I can sneak one and figure out if it really works. But I think that's one product that's gonna have to come here pretty soon. The people on the blog, the users, that gentleman that you see there, he still says that he's trying to check with his finger stick to make sure. It just came out in Europe in September. So we're gonna have to see where all that goes. So that's something good, because some of my patients who do not check just don't want to prick, and it hurts all the time when you do it. So I think that's a little bit of a light at the end of the tunnel. Maybe we'll have one of those in the next year or so. And then finally, I wanted to talk to you guys about the Bionic Pancreas. The Bionic Pancreas initiative it's been going on in Mass General. It's been going on for a couple of years. And what they're trying to do is for you to put something on. You don't have to check. You don't have to think. You don't have to tell the pump how much to inject. So what they're using right now 2 pumps. They're probably going to want to consolidate that to use only 1 pump. But right now they're using 2. This is just all in clinical trials. That's nothing it's available out there. And they use that hormone that we talked at the very beginning, the glucagon. So if your blood sugar would drop, it would give you a little bit of glucagon to bring it up. So that means I don't have to test my blood sugar and know that it's low and then go up there and eat a whole lot and bring my blood sugar to the 300s. The pump is going to do it for me. And it's going to give me a little bit of glucagon. The other one is going to be giving me insulin. So it's going to be a balancing act from the pump. It goes to an iPhone. The iPhone has some calculations in it. And then it will decide which one of the 2 to use. And right now, that pump is using its next phase, which is going now, is going to be using a Dexcom meter. So I'm very excited to see how this phase of that clinical trial works. One of the principal investigators from that study has a boy that's going to go to college in 2017. So he's saying we're all going to go bionic in 2017, because when he sends his kid to college, he wants him to be available to enjoy that technology so that he can feel safe that the boy went to college. And that's the glucosensing portion I already told you guys. It's Dexcom. This is one of the study participants I found online. If you see on, she's on top of a towel, and there's 2 green things. Those 2 little green things are her insulin pumps, and she's holding the receiver, which is on an iPhone. So even young kids would be able to enjoy that technology, which I think is probably the main focus, because those are really hard to control. How are we with time, Carol?
We're about there.
About there? All right, so I'm briefly going to touch base on some weight loss agents so that, you try your diet, you try to exercise, you're not getting all that you want from it. So patients with a body mass index of 27 and above and who have diabetes are candidates for some of these weight loss agents. Of course, you want to have someone who's really working a lot on diet and exercise, so before you try these agents. Phentermine, it has been around for a little bit. It's one of the cheapest products. You cannot use it for a long time. It's a stimulant. People with high blood pressure have to be careful using it, and if you also have thyroid problems. Glycemia is another product that's been around for 2 years or so. We've had very good success in this area with the product. Downfall, most insurances are not paying for it, but it has helped with very few side effects. If you're in childbearing age, you have to be on oral contraceptives because it can give some birth defects. So that's where the glycemia has had a little bit of a hold up to, and all those palpitations and some tingling and numbness in your fingers are just part of the substances there's 2 substances in it. We have Velvic, which also I haven't been very successful with because the coverage is very poor, but they're coming with a lot of offers now, so hopefully I'll have a chance to use it a little bit more in the future. Contrave uses 2 substances, and one of them is an antidepressant. It's called Wellbutrin that we've used for many years, and the other one is naltrexone, which kind of targets that center of reward of when I eat I feel good. So Contrave I've started to use. I haven't had a lot of patients back, so probably they'll be back in the next year or so, in the next month or so I'll see if it's really working. Something neat about Contrave is that they have an online program where you can go and they can send you a scale. You go on the scale sends a feedback to the computer, and that computer sends you text messages every day. Congratulations, you've lost half a pound, that was really good. Or, yeah, we gained a pound, maybe we should walk today, or maybe we should drink more water. And it's customized to you. You go on that program and you sign up, and it asks some things about your life so that they're telling you something to do. They're not going to ask you to go and walk the kids or go with your dog if you don't have a dog. Saxenda also has been approved. It's not out yet, but it is one of those GLP-1s that we talked about. You saw how it gave a weight loss benefit. Is in pretty much more than double the dose that we use for diabetes. Is that pretty much that Victoza and 3.0 dose. We only use 1.8 for diabetes, and it's going to come out soon. It did very well on clinical trials. We see how it does. Bariatric surgery is also an option to consider if you have diabetes and you have a body mass index of more than 35. Difficult to control with medications. You've tried lifestyle. Maybe that's something to consider. And the good thing is that 62% of patients can stop insulin 1 year after the surgery. So that's something pretty good to consider. So what I want you guys to take home is any weight changes, if it's up or down, fatigue, increasing urinations. Those are symptoms of diabetes. They need to be looked at. It's easy to diagnose. Simple blood work can do it. You don't have to go through days of testing. There are newer options to alleviate the burden that diabetes is imposing on you guys, so stay tuned. Don't feel discouraged in the next couple of years. Things are going to get better. Blood glucose levels at target can decrease the complications. So because we saw all the high risk of stroke and high risk of heart attack and people are going to die in 10 years, don't get scared with that. Just work on getting yourself under control, and then we can prevent all that. That has been proven in many clinical trials. And lifestyle changes are still required, even though you're taking medications. If you're not doing your part on diet and exercise, your blood sugars are still going to go up and down. We need to target that diet and that exercise. I thank you very much for sharing this hour with me today, and I welcome any questions.